Right then, you are watching Fiddling while Rome Burns, conducting research with healthcare staff when the NHS is in crisis. So today I'm going to talk to you about something that I've been noticing for a while that's happening in healthcare research, health services research, and that is the increased difficulty in researchers being able to undertake research with healthcare staff, but also patients as our NHS becomes significantly more underfunded and understaffed. I'm Laura Sheard. I'm an associate professor at the University of York in the Health Sciences Department. I moved there in January, and as you'll see from my Twitter handle, which is at Laura in Bradford, I live in Bradford and I work at the Bradford Institute for Health Research, which is based at the Bradford Royal Infirmary Hospital, for 7 years. So most of the work, nearly all the work that I'm going to talk about today and where my ideas have come from is based on the work that I was undertaking whilst I was at the Bradford Institute for Health Research. The paper on which this presentation is based was published in the Journal of Health Organisation and Management, last year ahead of print, but this year in print. An easy way to find the full text without need to going through a paywall is to click on my pinned tweet on Twitter, or you can find it by the citation on the right. So what do I mean by fiddling while Rome burns? Many of you have probably heard this phrase, but for people who haven't, so in July 64 AD, there was said to be a great fire, a massive fire that destroyed the city of Rome and burnt 70% of the city to the ground. It burnt for a week, and legend has it that whilst the city of Rome was burning down, Emperor Nero was 35 miles away at the time and decided to play his fiddle, so his violin, whilst the city burnt. So the phrase fiddling while Rome burns has become synonymous with someone undertaking a somewhat flippant or frivolous activity whilst a looming crisis or catastrophe is emerging or taking place. And I just wanted to talk a little bit about what do I mean when I say the NHS is a health system in crisis? Where have I got this from? So just a few headlines really that I've pulled from the press. So the winter of 2017-2018, the NHS was said to be facing a humanitarian crisis, and the British Red Cross actually warned about that as patients were dying on trolleys at several hospitals across the UK due to not being able to see medical staff in time. Here's a tabloid heading, hell at A&E. So disaster movie scenes where patients were stuck on trolleys for up to 15 hours. And then here's a headline from last summer. So the average GP waiting time exceeded 2 weeks for the first time ever. So that's patients needing to see a GP in the UK were on average waiting 2 weeks from last summer onwards. So how have we got into this mess, and what's some of the contributory factors towards this? So nursing degrees applications have slumped after the NHS bursary was abolished a few years ago. Massive drop in applications from applicants, particularly in England, particularly from mature applicants. GP vacancy rates are at the highest recorded level ever, with 1 in 8 positions unfilled nationally. And then Brexit as well, we can't ignore the cliff edge that we are rapidly hurtling towards. So by the end of next year, it's anticipated that nursing vacancies will top 51,000. There are currently 40,000 unfilled nursing vacancies across the UK. It's become apparent to me over, I think, the past 5 to 7 years, that healthcare staff engagement to take part in research is really low on some wards at some trusts. And the reasons for this are some of the reasons you see in front of you. So when I'm talking about staff engagement being low, I'm talking predominantly about engagement in studies where maybe it might be an interventional study, it might be about taking part in qualitative research or surveys, or it might be about staff being used as a conduit to identifying and recruiting patients for researchers to engage with. So more towards the social science end of healthcare and applied health services research, rather than the kind of RCT, medical clinical trial end. So just some of the reasons right in front of us. So just no time, too busy, undertaking clinical workloads. Some wards have 50% nursing vacancies on them. And then monetisation, having no incentive really. So providing locum cover so that staff can be released to take part in research activities, can't find any locums, providing overtime payments, no appeal after busy 13-hour shifts, and then ward staff being prohibited from taking part in research because all non-clinical activities have been cancelled centrally by the trust. So I've seen that quite a few times. So why does this matter actually? Why am I interested in this? Why am I bothered by it? Practically and emotionally, I suppose. I'm interested because healthcare staff being unable to take part in research due to the pressure on them in their clinical roles, it's often mentioned as a contextual factor which hinders research outcomes and practicalities and recruitment. So implicitly, where it's mentioned in the literature, it's said to be about inadequate staffing levels and lack of time and high turnover of staff, competing priorities, targets or metrics set by their management, or the way that the health service is continually reorganised and restructured. But what I think is missing is that a lot of studies talk about how this was down to individual context. So individual context at one or two trusts that they were working with led to these problems. So it was about, the local context and what was going on the ground there. I don't think this is an issue of local context. I think this is a national issue that is being explained away about local factors, but it's actually manifest right across the NHS. So here's a few examples of papers in the published literature that just caught my eye. I've been involved in a few of them, writing a few of them, but others that I just remembered because they struck a chord with me in terms of the authors being quite explicit about the difficulties that they had in recruitment in a health services research environment. And I find these papers interesting because although they are explicit about the problems of recruitment and staff engagement, they do kind of talk about the problems that they're having in more of a local context. This is a problem with the local context that they were involved in researching. And I just think that's really interesting because these are just a few that I've happened to pick out, but there must be scores more in the literature where people found that an intervention perhaps didn't work because of the context of where the research was being embedded and happening. So just to drill down a little further, Maxine Power has a paper in BMJ Open in 2016 where she coins the phrase structural turbulence in relation to her study that she was leading, which was a programme to improve patient safety at acute hospital trusts. And she says that it was the impact of structural turbulence which fundamentally influenced the lack of ability to achieve change in the health systems in which she and her research team were working. And I just really love that phrase, structural turbulence. So the NHS being in a time of rocky turbulence as a hindrance to research taking place. I also like to draw attention to the EPOC trial, but really I'm talking about the EPOC process evaluation. So EPOC was a massive RCT, and it was a quality improvement intervention which was designed to hopefully reduce mortality after patients had undergone emergency abdominal surgery. It involved, I think, half of all acute trusts in Britain, and when we look at the abstract, we can see that in the results of the process evaluation, one of the main findings was that the QI leads who were tasked with implementing the intervention were attempting to deliver it in challenging contexts. And the clinicians were trying to lead change in a time of limited time or organisational resources. So I really enjoyed reading that paper and seeing it in print, that mainly across half of all NHS trusts, this was one of the main qualitative findings that was put forward by the authors of the very large process evaluation. So obviously, I'm asking here, is it really context sensitive, as a lot of papers allude to? And you'll guess my answer already, no. I think this seems to be an issue across almost the entire NHS, across different settings, environments and clinical areas. But however, apart from a few slight nudges, there's really no current recognition in the published literature that this is a predicament that's becoming almost near universal. And that's leading to lots of different research teams trying to reinvent the wheel constantly, and maybe putting it down to local context and local circumstances as to why their intervention was unsuccessful, or they couldn't recruit staff or patients to take part in their qualitative or survey work. So I want to make it clear that each research team isn't having some sort of unique difficulty with staff engagement, and that really this is an NHS-wide problem. So obviously I pose a problem, probably need to pose a solution. What do I think can be done? Well, probably first and foremost, it doesn't take a genius to work out that if the NHS was funded at the appropriate levels, such as the extra £4 billion a year it is said to need simply to stay afloat, that might help matters, because staff would be able to have breathing space to maybe be able to take part in something that isn't their core clinical work. I also think healthcare research should be seen as an important part of the role of healthcare staff, obviously with adequate time and resources allocated to be able to achieve this. And I think researchers as well, we have a role to play in this, and I think we need to adapt and change with methods that move away from our methodological purity, like interviews and focus groups, where, we might need someone for 45 minutes to talk to us, but that person is never going to have 45 minutes that they want to spare. So in terms of this, adopting rapid ethnographic methods, or rapid evaluative methods perhaps, researcher and residence models, so when researchers actually move to become embedded in clinical teams rather than going into a team to extract data collection from that team. And also focus grouplets. So this is something that happened in a previous study, a qualitative study that was engaged with, where that was working on, where it was about just popping onto the wards and just hanging around and seeing when people had, the spare 20 minutes to engage with a researcher, rather than it being a set appointment time, which they then might need to cancel repeatedly. To come full circle then, I propose that conducting health services research is currently like the allegory Fiddling While Rome Burns. I do believe the NHS is in a dire situation at the minute. But I'm not actually, I'd like to make it clear that I'm not proposing that researchers are analogous to Emperor Nero, looking in on a devastating situation and doing nothing. I think we are trying to make great strides in flexing and adapting to this situation. But unfortunately, I think the devastation continues. And so I'd like to thank everyone for watching, and I'd like to hear people's views about this situation, and whether what I think strikes a chord or not with other researchers across the research spectrum.